Hello, good morning. My name is Michelle Booten, and today is 12/23/19, and I am recording this video to answer my case connections for Unit 4 for my class Medical Biochemistry at UNE. So I decided to answer Case 1 first. In Case 1 is talking about a newborn girl, appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. And then it asks you to decide which diagnostic test would be best to run in order to differentiate between a urea cycle disorder and a disorder in beta oxidation. So, and before I continue on, I am fighting a nasty cold or flu. So do please excuse me if I cough or start losing my voice or I need a tissue. So I'm already apologizing ahead of time. So to continue on, I would choose the plasma glutamine diagnostic test because if it is a urea cycle disorder, then the level would be elevated, but only for the urea cycle disorder. No matter what kind of disorder beta oxidation would have, the urea cycle, the glutamine level would not be changed. So that would be perfect. So then we would know if we see a normal level of glutamine, then it's not the urea cycle going wrong. It has to be beta oxidation from process of elimination. And then if it is wrong level, then we would have to assume that it's the urea cycle causing that or go into further diagnostic testing. I then also explained in my script about how I wouldn't choose the other options. So I decided I would not choose the blood glucose level because you wouldn't necessarily see a change, or at least a significant enough change in the blood glucose from either one of these deficiencies. The case doesn't explain to us whether this child has been fasting, whether they've been able to eat, keeping any food down, and even if they have been fasting, then it's very likely that the body is still in the phase of using the glycogen levels, that they haven't been depleted yet. So we might not even really see a great change because the body might still be able to maintain blood glucose level at that point. And then could really say the same theory for the serum fatty acids, unless the test showed that the serum fatty acids were high, then we could not determine where the defect is. And even if it was high, then I would actually start to look at, is there a carnitine problem? Why are the fatty acids not being able to enter the beta oxidation phase to be broken down? And then both disorders could show the same kind of effect for the urinary acid level, so a lowering of acid. If either one aren't working, but if both could show the same effect, then it doesn't really differentiate from each other. So, as I said before, I chose the plasma glutamine diagnostic test because it would differentiate between the two. Then it goes into the different levels, so high ammonia level, high uric acid level, citrulline level, and then it asks in this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is likely to be impaired. So since the uric acid levels are are elevated, I would naturally assume that there is a defect in the OTC. So I would naturally assume that because the citrulline level is still pretty normal, but the orotic acid levels are very high. So that would mean that the carbamyl phosphate is not being able to fully be processed through the OTC. So it's being rerouted because it's building up to become orotic acid. So then it can be disposed of. So, and then, like I said, we don't really see much of a change in the citrulline. I'm sure maybe later on we would start to see a drop in that. But the problem with the OTC could just be a deficiency. It doesn't mean that it's completely gone. You might still see it somewhat working, trying to do its job. So the least likely enzyme impaired would be the CPS1, and that's because we still see the carbamyl phosphate still present and being converted to the acid. If that enzyme was impaired, then we would see a decrease in that acid. We would see a decrease in the citrulline right off, which we do not see. So the OTC deficiency is actually a rare X-linked genetic disorder that causes total or partial lack of enzyme OTC. Symptoms such as lethargy, hypothermia, apnea, hyperammonia, which are all symptoms that we see in this case, are common with this deficiency and are pretty common in other urea cycle disorders. Excuse me. Since it is an X chromosome disorder, females are usually carriers and do not experience symptoms, but approximately 20% of female carriers do experience symptoms. The National Organization for Rare Diseases, or NORD, article that I have referenced below, all my references are within my script, but the NORD article said the study of blood plasma and urine is used to differentiate OTC deficiency from other urea cycle disorders. Individuals with OTC deficiency usually have both low levels of citrulline and high glutamine in the blood and high levels of orotic acid in the urine. It was written by Mew, and I ended with this statement especially solidifies my reasoning later, before, when I said that I would choose the plasma glutamine test, because this is showing that this exact deficiency would show up in that plasma glutamine test. And then on to case 2. So case 2 is talking about a patient A and a patient B. Both are infants and both are being looked at to possibly have PKU as a diagnosis, because both have high levels of phenylalanine, or PHE, which I will refer to as PHE just in order to move on quickly. So the first question is, as a consequence of this presentation, which amino acid may become essential? So the high level of PHE present means that it is most likely not being converted to tyrosine, important amino acid. So PHE, we obtain that through our diet. So could be eating all kinds of things that are providing PHE, but if it's not being converted to tyrosine like it should be, then we would see that high level, and especially with the diagnosis PKU. So if this child really does have that diagnosis, then that's what we would see. We would see very low levels of tyrosine and very high levels of PHE. So that would make tyrosine extremely essential for our bodies, because now it is really lacking that. And the enzyme that is not fully working or is not really present would be the phenylalanine hydroxylase. That is usually the problem for PKU, that it is lacking that enzyme in order to convert the PHE to tyrosine. Then we see that the PHE dietary restriction therapy works for patient A. And like I mentioned before, that is because the PHE is obtained by a person's diet. If the child has PKU, excuse me, then the PHE dietary restriction would help decrease those levels, because that's where we obtain it through, is our diet. And that restriction therapy is an extremely common treatment for PKU. And then it goes on to say that BH4 loading tests were performed on both patients. And then it shows that patient A's PHE level actually increased after the loading test, and patient B's greatly decreased. So, how would you summarize the results of this test for patient A and patient B? Patient A most likely has PKU because of the high PHE when they first presented, the decrease in PHE once they were placed on the restrictive diet, and then their PHE did not lower when they received the BH4 loading test. If the phenylalanine hydroxylase was still present and working correctly, then the BH4 would have helped decrease the PHE level, since it is the coenzyme to the conversion of PHE to tyrosine. But since my assumption is that this patient is missing that enzyme, the BH4 would not help that conversion, because you still need that enzyme to go with the coenzyme for that process to happen. So you would still see the high levels of PHE like we did with patient A. So, since loading tests did not help, I would start to assume that patient A has PKU, as did the doctors before. And then patient B was also being tested for PKU, since she or he must have had a high level of PHE as well. The results of BH4 loading test show that patient B does not have PKU, because the patient's PHE level would have remained the same after the loading test if they had PKU, but it did change, it lowered, and that is most likely because this particular patient has a deficiency in BH4. So without BH4, then that enzyme, the PHE hydroxylase, would not be able to do the conversion without BH4 as its coenzyme. So since they got the loading dose and the PHE levels dropped, then most likely their problem was a deficiency in BH4. So this deficiency in BH4 causes high PHE levels like PKU, but it can be treated with the BH4, and after the BH4 loading test is administered, you expect to see a lowering of the BHE level, as we did in patient B. And then I have my 3 references below as well for this particular case. And that is it. Thank you so much for listening, and I hope you have a great week. Thank you.